So changing a little pace here, we're going to go to the interstitial lung diseases. These are a little bit different diseases than obstructive diseases, than the obstructive diseases that we just talked about. So interstitial lung diseases, with all these diseases, they have a couple of common denominators, and we're going to talk about that. They have a lot of similarities. So if you remember just the similarities, then you could remember the specific diseases. There are some differences with the specific diseases, but they share a lot of common material here. So all these diseases, there's chronic inflammation. So something triggers a chronic inflammatory process in the lungs, usually at the level of the interstitium. The interstitium is the lining around the alveoli and at the alveolar level. So for example, in people that have asbestos exposure, it's the asbestos fiber that they breathe down, and this triggers an inflammatory response. And then what happens with chronic inflammation, because this continues, it's chronic inflammation, there's eventually fibrosis of the interstitium. And then when this happens, when there's fibrosis around that area, gas exchange is disrupted, and these patients become hypoxemic. They all share similar clinical symptoms. The number one reason they come to the physician is chronic exertional dyspnea. So this patient says, I get short of breath when I walk, doctor. And then you say, like, well, how long has this been going on for? He said, well, it's the last month or so that this got worse, but I actually have it for at least 2-3 years. And that's the chronic, and it works up. First it's mild, and then eventually the last couple of months before they come to the physician, they tell you, I walk across the street and I get short of breath. On the exam, you may find fine crackles, especially in some diseases like idiopathic pulmonary fibrosis. At the bases, it's common to see things like that. And then some other stuff that are related to the chronic lung disease, the clubbing. You may see clubbing in their fingers, and you may have evidence of cor pulmonale, right-sided heart failure, if the pulmonary disease has been extensive. And so all these things, all the interstitial lung diseases share this. They have the same presentation. There is no difference, and there's really no way to tell the difference just on presentation. They also share common X-ray findings. So, for example, they all have a reticular pattern, and some of them show this thing called a ground glass appearance. This occurs with chronic inflammation. This ground glass appearance. And then they have similar pulmonary function tests. So all of these show intrapulmonary restrictive disease and then a decreased DLCO. When I say intrapulmonary restrictive disease, I'm sorry, I should say the intrapulmonary restrictive disease. Along with that is a decreased DLCO. That's what makes intrapulmonary restrictive disease, because if you just have a restrictive disease on the pulmonary function test, you can't tell the difference between extrapulmonary restriction, remember the kyphoscoliosis, the morbid obesity, versus intrapulmonary restriction like idiopathic pulmonary fibrosis, like sarcoidosis, like pneumoconiosis and so forth. The only thing that tells you the difference between one and the other is the decreased DLCO, which you only find in interstitial lung diseases in the intrapulmonary restriction. So intrapulmonary restrictive lung disease, along with that, the DLCO is part of that. So the workup is similar. After you do the initial chest x-ray, you do a high-resolution CAT scan to see what part of the lung is mostly affected, to know what to look for. And then the most appropriate step always in the end of these diseases to confirm the diagnosis, sometimes just to exclude other diseases, because some of these diseases don't have a pathognomonic finding, but they have certain findings that look a certain way, and then you exclude certain other diseases, and then you say this is the likely diagnosis. So always in these cases, we start off with the x-rays. We may do pulmonary function tests to see restrictive disease, or we may get the pulmonary function test because we're thinking something else, like a COPD, and then we find intrapulmonary restriction. That's similar to all these diseases, and then the workup is similar. After all this, it's after you do the chest x-ray, you do a high-resolution CAT scan, and a biopsy to confirm or exclude the diagnosis. Now look at this. This is all the interstitial lung diseases. There's over 100. Some people say it's probably over 200 diseases, and there's a lot of them here, and we're only going to cover certain of them, but basically just to give you an idea, when you see intrapulmonary restriction and a ground glass appears on the x-ray, there's a lot of diseases you need to cover. That's why you do the high-resolution CAT scan and the biopsy. So some of them, idiopathic pulmonary fibrosis, sarcoidosis, the occupational lung disease, a big category here. That's why they say, what is one of the most important things that we get in patients with interstitial lung disease? The answer is you get a good history, occupational history. You make sure they weren't exposed to something you should be looking for. Silicosis, asbestosis, and all that stuff. And then there's the autoimmune diseases like lupus, like Wegener's disease, sometimes rheumatoid arthritis, and so forth. And then there's some weird diseases like eosinophilic pneumonia and Sturge-Strauss syndrome and so forth. All these, along with another 90 of them, are part of the interstitial lung disease continuum. Let's do this case, and then I'll tell you the diagnosis a little bit, and then we'll go back and ask some questions about it. A 55-year-old man came to me for the evaluation of dyspnea with exertion over about 6 months. He says that recently walking across the room has become difficult. He has no significant past medical history. His respiratory rate is 24. His pulse is 106. His physical exam shows a positive increased jugular venous distension, so he's got right-sided heart failure right away. You find lung exam that shows fine crackles on inspiration, positive clubbing, and a positive trace edema. So when I first heard about the JVD on this guy, I said, well, he's got heart failure for some reason, but he had no hypertension, no hyperlipidemia in the past. And then on exam, we find the fine crackles, the clubbing, which shows chronic lung disease, the trace edema that goes along with cor pulmonale, and then I do the chest x-ray, and look, I find this diffuse reticular nodular pattern in pretty much a normal heart size. So this guy has some form of interstitial lung disease. Now the question is what? And what this guy had is this thing called idiopathic pulmonary fibrosis. It's a chronic lung inflammation. It occurs out of the blue with no precipitating factor. It's of unknown etiology. And the interesting thing about this disease is it has no other systemic manifestations. What I mean by that is it doesn't involve other organs. It only involves the lung. It usually occurs about the 5th decade of life, and the typical presentation with the interstitial lung disease will dyspnea on exertion, fine crackles on the exam, maybe clubbing, maybe edema and JVD because of the cor pulmonale, and the ground glass appearance on the x-rays usually involving the lower lungs. The bronchoscopy and lavage are nonspecific, but they include the other disease. For example, this guy, we just found inflammation. Nothing much, but it excluded other diseases like pneumoconiosis, like sarcoidosis, like autoimmune diseases. The treatment for this disease, then I put a question mark here, are steroids, because only about 1/5 of these cases really respond to steroids. The rest don't. And we have to think about some other things to do in these patients. So some of the immune agents have been used, like azathioprine, cyclophosphamide, 6-MP, and so forth in these patients. And a lot of patients are looking, a lot of physicians are looking at these patients now to try to do a lung transplant or a heart-lung transplant. That's the definitive treatment in these patients. So a progressive chronic lung disease, idiopathic pulmonary fibrosis, the triggering event that causes all the inflammation, we don't know why these people get it, but we don't know the etiology, but it goes on for a long time, it's relentless, and the treatment is questionable with the steroids, but that's where we start off with. So going back to this case, I'm going to ask a question or two. A 55-year-old man that comes in with dyspnea on exertion for over 6 months, he says that recently walking across the room has been difficulty. He has no significant past medical history. His respiratory rate is 24 and his pulse is 106. It's the same case. And now we find that he's got JVD and so forth, the clubbing, the crackles on inspiration, and the reticular nodular pattern on the x-ray. The bronchoscopy and lavage show no granulomas, chronic inflammation with increased macrophages. That's the typical thing that we find in IPF, idiopathic pulmonary fibrosis, chronic inflammation, nonspecific, with increased macrophages. This is not pathognomonic for anything, but look, I've ruled out other stuff. No granulomas, right? So no sarcoid, nothing else there. I ruled out, pneumoconiosis because I didn't find any fibers there consistent with pneumoconiosis. And there's a lot of other things. I didn't find eosinophils there that would point to eosinophilic pneumonia and so forth. So I'll make the diagnosis because I've excluded all the other stuff and because this person fits the pattern of idiopathic pulmonary fibrosis. Now here's the question. You have made the diagnosis of IPF in the previous patient based on the bronchoscopy result, excluding other diseases. After discussion with the patient and his family, you have decided to start oral prednisone at 60 milligrams daily and make an appointment to see him after 3 months. What is the best follow-up test for response to treatment? So they say, when he comes in 3 months, you're going to ask him, sir, are you short of breath again? Do you have dyspnea in the air? The patient's going to say, yeah, I do. Have you seen any difference from, the last time? He may say yes, he may say no, but you want a more objective way to measure this. You put somebody on prednisone, they may feel better because, the prednisone makes them feel better 3 months later. That doesn't mean that though this made their, improved their disease in the lung. So the most important test is to find an objective way to measure lung function in this patient. So the right answer here would be to follow up lung function in this patient. I would do a pulmonary function test. And I would compare my FEV1 now to the FEV1 I had before, something like that, or the total lung capacity and all the volumes to the volumes I had before to see if there's any benefit. So if I went 1 year later and I had this patient on prednisone and there is no benefit, because I objectively measured pulmonary function tests, then I would say he fits into the 80% of patients. And since there's no benefit, I know in 80% of patients, I'm going to stop the prednisone. Versus, if I see an improvement of FEV1, if I see an improvement of lung capacities, then I'm going to continue the prednisone. So that's the way we manage these patients with the pulmonary function test to see if they really are doing well with the treatment. So another type of interstitial lung disease, but these patients have not, I put it under interstitial lung disease because that's the typical pattern you get when you have stage 3 and 4 of the disease. But these patients may sometimes present with just pulmonary nodules or hilar adenopathy. So it's not the typical interstitial lung disease, but I want to put it here because sarcoidosis is a very important disease. We see a lot of cases in this country, and we get asked on about this disease because we're going to see a lot of patients. So let's go to the case. A 27-year-old woman comes to your office with painful erythematous papules. She also has had joint swelling for a few days, and she says, yeah, it's symmetrical polyarticular arthropathy, right? She shows you all her small fingers in her joints in her hands are affected, and so she has symmetrical polyarticular arthropathy, and on the exam you notice these painful erythematous papules. They're well demarcated, 3 centimeters over the anterior leg area. What would a chest x-ray be consistent with? And they say, well, what would you do in this patient to diagnose? What she has is called acute sarcoid. So acute sarcoidosis presents with a combination of erythema nodosum. That's what these painful erythematous papules are. Erythema nodosum. It's a hypersensitivity reaction. And then you have the arthropathy, symmetrical arthropathy. And then the third one is the pulmonary findings consistent with hilar adenopathy, bilateral hilar adenopathy. So what would the chest x-ray disclose? The answer is bilateral hilar adenopathy. That's how you make the diagnosis of acute sarcoidosis. And this is a very common syndrome. Now, some people say, look, treat these patients with prednisone. Acute sarcoid, not everybody agrees, but treat these patients because they have severe arthropathy, right? They have the erythema nodosum, it's painful. So treat the patients with steroids. It's important to make the diagnosis. So sarcoidosis is a chronic granulomatous disease. These patients have non-caseating granulomas compared to caseating granulomas where you see in tuberculosis. Non-caseating granulomas are not pathognomonic of sarcoidosis. There's other things that do that, but the whole spectrum of the disease, along with the non-caseating granulomas, makes your diagnosis of sarcoidosis. So chronic granulomas, non-caseating, and we don't know the etiology. The etiology, some people say, is maybe infectious. It may be something environmental. Some people of African descent are more common to get it. Some people in certain Mediterranean areas are common to get sarcoidosis. We don't know the etiology. People have been looking for it, and nobody has really pointed to something that's evident to cause sarcoidosis. But these people have the most common organ involved are the lungs. The lung is the most common organ, and the most common presentation of lung involvement is bilateral hilar equal adenopathy. So I'm saying it here. I want to make sure everybody understands. It's hilar adenopathy, but it's bilateral equal hilar adenopathy. That is, versus other diseases like tuberculosis or lymphoma, which cause hilar adenopathy affecting only one side and not the other side. So this is bilateral, both sides, and usually, most of the times that we see sarcoidosis, it's an unexpected finding on chest x-ray, and these people are usually asymptomatic. They're not like the acute sarcoid that I just presented. They get an x-ray, and we see it on the x-ray, hilar-adenopathy. The patient has no symptoms at all. That's the most common presentation. Now, there's other manifestations. This is a systemic disease. So there's other manifestations, skin manifestations, like erythema nodosum, like lupus pernio. You may hear about that thing. It's not like systemic lupus. Lupus pernio, it involves the face. These patients have sarcoid. Eye manifestations, uveitis, conjunctivitis. Joint manifestations, like symmetrical swelling on the joints like this patient had. Central nervous manifestations, so some of these patients have severe manifestations like CNS manifestations, and manifestations of the peripheral nerves like mononeuropathy, foot drop, wrist drop, and so forth. Gastrointestinal system, sometimes they have the GI system, the esophagus involved, and then rarely things like the kidney. So what do we find beyond the physical presentation, the physical examination and the symptoms? The laboratory findings sometimes disclose hypercalcemia. It's a very interesting form of hypercalcemia in that these patients commonly have hypercalcemia, and this is due to hyperactivation of vitamin D through the macrophages. So it's interesting that there's vitamin D activation through the macrophages. That this is it doesn't happen anywhere else where we see that, and it usually happens in the summertime in these patients when they either move to sunny areas in the world, because now they absorb more and more calcium through the through the sunlight, so they get hypercalcemic. The prognosis is pretty good. Most of the people presenting with lung disease, the prognosis is pretty good, and I want to make sure people understand that no matter what you do to these patients, 80% will improve without treatment. So I know when we see somebody with active sarcoid of the lung or symptomatic sarcoidosis of the lung, right away when we talk to our pulmonary specialist, they say, yes, treat this patient with prednisone right away. But the studies have shown that 80% of these lung lesions, no matter what you do to them, will improve. That's why sometimes, waiting as long as they don't have any other manifestations is sometimes frugal and good. The diagnosis is made through biopsy of involved tissue by showing non-caseating granulomas and excluding other diseases. So, for example, if the patient had lung disease, you go in and bronchoscopy and take a chunk of the lung and then show the non-caseating granulomas, and you exclude cancer, you exclude tuberculosis, you exclude other stuff, fungal infections, and that's how you make the diagnosis. Now, some older literature have indicated that by measuring angiotensin converting enzyme levels, you can make the diagnosis of sarcoidosis, and please do not make that mistake. They've done a study on angiotensin-converting enzyme levels. They're totally nonspecific and they're totally non-sensitive. So we can't make the diagnosis based on ACE levels. The diagnosis is a clinical diagnosis plus the finding of non-caseating granulomas on tissue biopsy. The treatment are the steroids. And I told you, well, when do we use for steroids? Well, the lung, 80% of the time it gets better, so maybe the answer is not always in the lung. You know, you have to talk to the specialist about that. But there are some scenarios where we have to use the steroids. And number one is eye manifestations. Eye manifestations occur with sarcoidosis, and they can lead to scarring and sometimes, rarely, blindness. So these patients have to be treated with steroids. Sometimes some people say with minimal disease you could use just a steroid eye drops. That's good. It's good enough. Sometimes you have to use systemic steroids, but you have to use some type of steroids when the patient has sarcoid involvement of the eye. Central nervous system disease has to be treated with steroids, systemic steroids. Hypercalcemia has to be treated with systemic steroids. They have to get steroids for that. The lung is a question. Acute sarcoidosis, like our patient presented, well, some people say, you know, treat with steroids also. Some other people say, you know, wait and watch and it goes away after a couple weeks. So, but the most important ones, the eye, the central nervous system, the hypercalcemia, those are the only ones that we may be asked about when to treat with steroids. Before I go to this case, I want to tell you one more thing. The way that we follow sarcoidosis is, remember we said about the ACE levels. We said, well, we don't make the diagnosis of sarcoidosis with using the angiotensin-converting enzyme levels, but there's some literature to say that if you want to follow disease activity and check for exacerbations of sarcoidosis, an ACE level may be good for that. So the angiotensin-converting enzyme is not a good test to diagnose sarcoidosis, but you may be able to follow disease activity and treatment with the ACE levels. So if they ask us what is the only thing that ACE levels are good for, that's it, to follow disease activity and treatment. So if a patient had a high ACE level when the disease was active, once you treat it with prednisone and you're treating it well, it'll go down. If it doesn't, you know, go down, well, you need some more medication or you're not giving them enough, and so forth. If a patient comes in with joint pain and stuff like that, and you find the ACE level elevated, maybe this is telling you something. It's telling you that this is from the sarcoid exacerbation, and so forth. So only use it in that case. So let's go to this case. A 27-year-old man is found to have bilateral hilar adenopathy on routine chest x-ray taken before starting his new job. So this guy is totally asymptomatic. He was going to work in a hospital, got a chest x-ray, and now he's got bilateral hilar adenopathy. He has no symptoms and feels well overall. The physical exam and the lab tests are unremarkable. What do you plan to do? Believe it or not, you watch this patient, you don't do anything, you watch him, and you bring him back 2-3 months later, and you examine him again, make sure they have no symptoms at all, and you repeat a chest x-ray and make sure it didn't change. So let's go back and let me explain to you why you do this. I told you the most common presentation of sarcoidosis is not symptomatic disease, it's asymptomatic hilar adenopathy. And that's usually we find it on some kind of routine x-ray done for other reasons. Now, remember, I said, look what this guy has, bilateral hilar adenopathy. That's sarcoidosis, not unilateral, not bilateral and symptoms. That's, you know, that may be sarcoid, it may be lymphoma, it may be tuberculosis. So in those cases, when the hilar adenopathy is unequal, or the patient has systemic manifestations, you have to go in there and biopsy tissue and prove that the patient doesn't have something else. But if a patient is asymptomatic and has bilateral hilar adenopathy, this patient, you could say, okay, this is consistent with sarcoidosis. I'm not going to do nothing. I'm going to watch him for now. and then bring them back 2-3 months later and make sure they're asymptomatic and their exam hasn't changed and their chest x-ray hasn't changed. If the x-ray and the exam changes, you have to go biopsy that tissue. If it doesn't change, then you bring them back 3-4 months after that, and if they're stable now and they don't change, maybe bring them back, you know, one more time, and then if they're normal, then you don't have to do anything more, and just tell them that this is sarcoid, so he knows later when they get another chest x-ray not to be questioning him what he has and so forth. So please, in this case, watch and wait. That's the best approach to this case. So the third type of interstitial lung disease that I want to talk to you about are these very interesting diseases called the pneumoconioses. So these are occupational lung diseases, and the process is that these patients it's an occupational exposure. For some reason, they're not wearing the protective garment, or the company doesn't give them the protective garment to wear, but they inhale the fibers, and these go down into the alveoli. They cause an inflammatory process. Alveolar macrophages are recruited. A chronic inflammatory process occurs, and fibrosis occurs, chronic fibrosis in the lung, the typical that you find in any interstitial lung disease of any cause after chronic inflammatory, chronic inflammation. Eventually these patients get fibrosis. The three basic diseases, and there's two of them that are more important than the other, are asbestosis, silicosis, and co-workers pneumoconiosis. Now, asbestosis and silicosis are the two most important ones. They're very important for the boards and for our clinical practice. We see a lot of these patients. Co-workers pneumoconiosis, there's just something to know about this that's very interesting. So usually these diseases occur about 20 to 30 years after exposure. And like I said, they present with the classical interstitial lung disease presentation. Dyspnea on exertion, maybe clubbing, interstitial pattern on the CAT scan and the chest x-ray. Two things that we may be asked. One is, in occupational lung diseases, what is the most important thing that the physician has, most important too? And the answer is right here: history of exposure. So history, an occupational history here, is the most important thing in making the diagnosis of occupational lung disease. Very, very important. And then the second one that's also very important: do we always need a biopsy when we are thinking about pneumoconiosis? And the answer is, we always need a biopsy. We said we always do it in interstitial lung disease of any sort, but especially if you're thinking about occupational exposure and occupational lung disease, it's even more important to push for a biopsy. Why? Because of litigation issues, some of these patients cannot be compensated later unless you prove that this patient has been exposed occupationally. So you go back 30 years later and, you know, try to find the company to basically pay for this patient's care sometimes. But you can't do that unless you've proven that this patient has you know, the disease itself. It can't be an x-ray that looks like sarcoidosis, that looks like asbestosis or silicosis. It has to be a biopsy-proven specimen. So a couple more things. We want to talk a little bit about asbestos. The asbestos fiber looks like a little dumbbell. I'm going to show you an x-ray of that, or a finding from a biopsy specimen in a little bit, what it looks like. The asbestos fiber, that's the one that goes down into the macrophages, and it starts the inflammatory process into the alveoli, and it causes the macrophages to start involved in the inflammatory process. It usually involves the lower lung fields. And that's the typical presentation of asbestos, the lower lung field involvement. And then some other findings that are very almost pathognomonic of asbestosis, these things called the pleural plaques. So pleural calcifications, they occur in no other interstitial lung disease, so they're almost pathognomonic. Now, where's the occupational exposure? So this part here is very, very important. They ask us, what is the occupational exposure you got to get from these people to make sure that, you know, there really is such a disease here, and we have to look for it and get a biopsy. So there's three types of occupations that are that are high risk for asbestosis. The shipyard workers, especially people that painted ships, there was asbestos in the paint and in the ship for insulation purposes. And then people that worked in housing and stuff like that for insulation, that's another big category. And then the third one, people that worked in the brake linings for cars. The brake linings used to have a high asbestos. The lining there was from asbestos, and when they would change the brakes, that's all they would do. They get asbestos exposure and develop the asbestos lung. What are these people at risk for? Well, they're at risk for interstitial lung disease and eventually lung failure, but they're really at risk for, especially if they're smokers, for bronchogenic carcinoma. So these patients have a 75 times the chance of a normal patient to develop lung cancer if they're smokers, 75 times above a normal patient. So very high risk for bronchogenic cancer. Now the classic teaching is, what are asbestos patients, asbestos exposed patients at risk for? And everybody says mesothelioma. They are. Mesothelioma is a pleural cancer, right? And it's not as nearly as common as bronchogenic cancer. So the number one cancer in patients with asbestos is lung cancer, not mesothelioma. Please remember that. And what could you do for these patients is, I just told you, if they're smokers, they're 70 times the risk, 70 to 75 times the risk of a normal patient. Tell them to stop smoking. That's the only thing that you could do for these patients. So let me show you a couple things here. These are important x-rays that we have to know, because they sometimes may ask us, look at this, look at the pleura here, look at the calcifications, look at the pleura here, look at the calcifications here, right? Look at the lung disease involving mostly the lower lobes here, right? The upper lobes, well, there's some involvement, but mostly they're okay. So lower lobe involvement, maybe a pleural calcification here, one here, this is calcification, a pleural plaque, and here's the other one. And look at this well, because here's the other thing, the asbestos bodies, right here, these dumbbells here, right? This is from a biopsy from lung tissue. You have to confirm that in order to make the diagnosis. And what do we do to these patients? We can't do anything, right? We have to go back and make sure nobody else is getting exposed. So, for example, in the Midwest, they found out that people were coming in with certain asbestos exposure. They had to go back and find out where this exposure was happening, and it was happening until recently. So you have to go back and make sure that you follow that exposure and make sure nobody's getting exposed to now. You have to confirm the diagnosis in this patient for litigation purposes later, and you have to tell them to stop smoking because of the risk of lung cancer. Silicosis is the same concept. Now the patient takes in silica dust, and the association here is different. It's the sandblasters that get this. Mining, people doing certain mining, you may find silica dust there. And that's the other people that do the quartz work. There's a lot of silica in the quartz work. You always see now the companies making a big deal about these patients working with glass and pottery, wearing all the protective stuff in order not to be exposed to silica dust and get interstitial lung disease. Now, here's the interesting thing. For no reason, that anybody knows about, asbestosis involves the lower lungs, but silicosis involves the upper lungs. And that's that's the typical pattern that silicosis follows. And sometimes you may get a nodular pattern. Sometimes you hear about these egg cell calcification of the lymph nodes. And the risk here is not so much cancer, but these patients are at risk for pulmonary tuberculosis, and it makes it really difficult to diagnose pulmonary tuberculosis in these patients, because remember, I just told you that, look, the upper lung fields are involved in this case, right? So upper lung fields are involved. Post-primary tuberculosis involves the upper lung fields. So there's a lot of scarring in the upper lung fields in silicosis, right? So they can't see anything in there if there's active tuberculosis. what they tell us about silicosis, because they're at such high risk for pulmonary tuberculosis, and because you could have, you know, the pulmonary TB is behind the scarring and you can't see it well, so you can't find it because there's so much interstitial lung disease there. They tell us for these patients to always check a PPD every year. And if it's positive at any time, they're to be treated for latent tuberculosis. Treated, I mean, for non-active disease, because they don't have symptoms yet, they just got infected. So check them for latent TB with a PPD once a year. Positive in these patients is considered 10 millimeters or over. That's what's considered positive in patients with silica dust exposure. The last one I want to tell you just one thing about, they may ask this because it's kind of bizarre, is patients that have cold workers pneumoconiosis. Now, these are the people with they get the coal dust, the miner's lung. That's what this was called, and this is associated with the type of coal. The type of coal. Not all coal miners get this. It has to do with the hardness, the quality of the coal, and it usually, just like silicosis, involves the upper lung fields. And they get these small round densities usually in the upper lung fields. But here's the most interesting thing, and nobody knows why this occurs, that it's associated with immunologic abnormalities. These people, for some reason or another, have immunologic abnormalities. So, for example, they may have an anti-nuclear antibody positive. They may have complement levels, C3 and C4, decreased. They may have IgG elevated and IgA elevated. They may have even a rheumatoid factor positive. There's a specific disease, and that's a kind of way that you kind of remember it. It's called Kaplan syndrome, where patients have rheumatoid arthritis, Kaplan's with a C, right? They have rheumatoid arthritis, and they present with rheumatoid nodules in the lung, and at the same time, the patient has some form of cold workers pneumoconiosis. So the combination of cold workers pneumoconiosis and rheumatoid arthritis of the lung with rheumatoid nodules is sometimes referred to as Kaplan's syndrome. And if you remember that, you'll remember that these patients with cold workers pneumoconiosis also have commonly associated immunologic abnormalities for reasons we don't exactly know. And this completes the interstitial lung disease section.